What is unique about Bertolotti's 2 is that a SPECT scan or a CT scan that will show activity within the bone structure would normally be negative. You would normally think that pseudoarticulation would show a positive SPECT scan. In speaking to various surgeons, I found that this is actually usually negative in most of these patients, which is of a bit of a surprise. Also, before the patient were to go to any type of surgical consultation, what I've also found from speaking to several different neurosurgeons is that a CT scan with 1 millimeter slices is recommended. As noted before, what is also diagnostic and therapeutic will be an injection into the pseudojoint. Sometimes this can be very effective as far as reducing or eliminating some of the patient's pain, albeit temporary at times, but it's also diagnostic, so now we know and identify the primary pain generator, which could be stemming from the pseudojoint. If this is ineffective, sometimes the patient may benefit from a plain epidural steroid injection, which will be performed higher or into the epidural space above the fusion site. This will help reduce significant inflammation, usually within the disc above the Bertolotti's region. When it comes to surgical indications for Bertolotti syndrome, this is a new and evolving arena. Currently, patients with Bertolotti syndrome who are surgical candidates are a type 2 or a type 4 transitional vertebra. Type 3s are non-surgical, from my understanding and speaking to several neurosurgeons, and type 1s typically do not go to surgery. They can be handled by conservative means. My current understanding is most patients will undergo fusion of the Bertolotti's region, which will usually be L5 to the patient's sacrum. Sometimes this may be coupled with resection of the spatulated transverse process. The goal is to provide decompression of the surrounding nerve roots or the exiting nerve roots adjacent to the spatulated transverse process. Some of the limitations as far as surgical recommendations and indications are because there's very few surgically literate neurosurgeons. Currently, we're working with Dr. Michael Steinmetz at the Cleveland Clinic and Dr. Art Jenkins at Jenkins Neurospine in Manhattan in helping filter out some of these cases and also referring patients to them who have failed conservative care and have no other option but to seek surgical consideration. What is unknown at this point is what occurs 5 and 10 years down the road after they have a resection or fusion. Currently, the data is looking promising. Obviously, best practices have yet to be established, and I'm sure they will be once more time goes by, once more patients are actually undergo a surgical procedure for this.